This program is brought to you by Emory University.
It's a real privilege to introduce today's speaker. I think most of people who've been at Emory for any length of time know Dr. Umpierrez. He's the diabetes guru of Emory, has been at Grady for many, many years. I think he's been at Emory for more than 30 years. Is that right? As a professor in the division of endocrinology. And I personally have been working with him for maybe 15 years. We've done clinical trials, a lot of vascular testing, etc. He has many, many achievements in his life. He's a great educator. He's on the training grants. He's continually been funded by NIH and many other investigator-initiated studies, etc. And much of what I know about diabetes has been through working with him. So thank you, Guillermo, for doing this.
Thank you so much, Anna. So I guess it's a challenge to talk diabetes on the cardiologist. Now you are using all of our drugs. So what I'll do is I've been involved with the professional practice committee, and we just published the new guidelines last month. So let's start. And we'll start with this. I mean, Emory University has received funding for these investigator-initiated studies. And I've done advisory board for these two companies. So this is the learning objective. Review what the ADA would suggest you to do and discuss what important factors, how we have changed during the past 2 decades, how we manage people with diabetes. And I put these 5 together for you. And what is amazing is that during the last 20 years, we have doubled the number of people with diabetes in this country. So in 2004, 18 million, we're now 5 million in 10 years, 5 more millions in the next 5. And right now, we think that we have 38 million people, or 11.6% of the adult population having diabetes. And what is important is that despite the numbers that are overwhelming, is that, well, 1 in 5 don't know that they have diabetes. And more importantly are these guys here in the bottom, the pre-diabetes. So if you have pre-diabetes, you have about somewhere around 40 to 50% chances to become diabetics in the next 5 years. So if you now 38 and you have 98, I mean, it will be easily understood that in the next 5 years, we're going to surpass 45, 50 million people with diabetes. And unfortunately, it's a disease of minorities. And if you look here, the prevalence of diabetes in men and women, Caucasians, look at the Latinos, African Americans, and of course, Native Americans. So amazing the impact they have in social determinant of health. And you may not or may remember what you learned in medical school, that diabetes is the #1 cause of blindness in the adults. If you have diabetes type 1, 20 years later, 99% will have retinopathy. If you have type 2, 60%. It's the #1 cause of nephropathy, the need for dialysis, 45%. Here at Emory, we're doing tons of studies on end-stage kidney disease and diabetes. We have 850 patients with dialysis. 46%, 45% of our Emory patients have diabetes. It's the #1 cause of amputation not related to trauma. And if you see somebody who is missing a limb, very likely has diabetes. 75% of those who get amputation have diabetes. And stroke and heart attack, cardiovascular disease is increased by 2 to 4-fold, and mortality and stroke. So if you look, and I do a lot of research in the hospital, and this is 7.8, this is the ADA, but the CDC just published last month, there are 8.25 million people admitted with the primary diagnosis of diabetes. And if you look, #1 is cardiovascular disease, ischemic cardiovascular disease, and stroke, 321 million people. So there's no question that every cardiologist needs to understand how you manage people with diabetes because the great impact that you have in your specialty. And you have 160,000 amputations. A Grady hospital has 265 amputations last year, 260 in one hospital. And the hyperglycemic crisis, 250,000. And it's very expensive. $413 billion cost to take care of diabetes, and taking care of a patient with diabetes is more than twice the cost of people without diabetes. So with that introduction, I think that I hope that I call your attention on the importance of diabetes on everywhere, every specialty, especially cardiovascular disease. So when you look at what are the goals when we deal with diabetes, and I'm going to be very practical. And if you have a question, you don't agree, just shout it and let me know. So we want to improve diabetes control. And glycemic control, although has changed a lot during the years, is extremely important to prevent small vessel disease, the retinopathy, the nephropathy, the amputation. Not as much for cardiovascular disease, but we want to look for cardiovascular risk factors to treat them very aggressively in these patients. And also now we have new evidence on cardiorenal protection. And I'm going to discuss very brief about obesity. That's right. There is 1 billion people around this world who has a BMI greater than 30. And the United States lead the group, optimize quality of life. So what are the goals? So this is what the American Diabetes Association and the European says, keep the hemoglobin A1C less than 7%. And the College of Endocrinology, a little more aggressive, that you have to really individualize care. So if I get diabetes, I mean, I'm in the 60s, I mean, if you have 30s, it depends who you are and the comorbidities. But in general, we would like to have a hemoglobin A1C less than 7 for most people. So this 7 came up from studies done in the 90s. To the left is a study in type 1 diabetes that is called DCCT, or Diabetes Complication Control Trial. And what you see is with increased hemoglobin A1C, you have an increased rate of microvascular complications, the eye, the kidney, the legs. And to the right, another study is done in the 90s in patients with type 2 diabetes that is called the United Kingdom Prospective Diabetes Studies. With increasing hemoglobin A1C, significant increased rate of microvascular complications. And there is not significant, although impacted on myocardial infarction and macrovascular complications. But there is no question that for the eye, the kidney, the legs, having a good glucose control, with just a difference of 1% hemoglobin A1C, you prevent nephropathy, retinopathy, and death. For each reduction of hemoglobin A1C, going from 10 to 9, 9 to 8, whatever, you reduce death by about 20%, microvascular complication 37%, and myocardial infarction 14%. So the importance of diabetes control is there. So, So for many, after following these studies, there's this question about myocardial infarction, macrovascular complications. So the question in the 80s and in the 90s to year 2000 and 2005 was, if you bring the blood glucose down, do you impact on the rate of cardiovascular outcome? So there were 3 large studies. One is called the ACCORD, done in the United States with more than 10,000 patients. The other is ADVANCE. We have 180 patients here in the Emory system. ADVANCE, done mostly in Australia, New Zealand, Canada, with oral agents, and VA-DT, or VA diabetes trial, the 3,000 patients. So 23,000 patients in these 3 studies. And the question is, if you push hard to bring the hemoglobin A1C less than 7 or even less than 6.5, do you reduce cardiovascular outcome? And the answer, unfortunately, was no. And more importantly, this study here that is called the ACCORD, that you wanted to bring the hemoglobin A1C less than 6.5, we did harm. And the study was stopped because of the increased mortality in this patient. So we tried to bring hemoglobin A1C to reduce cardiovascular mortality, but it didn't work. And here, for example, are these meta-analysis that clearly shows that improving hemoglobin A1C doesn't really change much the outcome on cardiovascular outcome. And if you try to push hard, and these studies were done now 10, 15 years ago, before we have the GLP-1, before we have the SGLT2s in this world. So we were using sulfonylureas and insulin and multiple drugs. And of course, the problem was hypoglycemia. So if you push hard with certain drugs to bring the hemoglobin A1C less than 7, less than 6.5, you get hypoglycemia. That increased the risk of cardiovascular complications. So for many years, we were safety, efficacy. So I hope that you are with me on the importance of bringing the hemoglobin A1C down, improving glycemic control, if you can, because it prevents nephropathy, retinopathy, amputations. But it doesn't help much with cardiovascular disease. The second point so far is that you have to do it preventing hypoglycemia. So right now we have several drugs that are very effective with no hypoglycemia. And the other thing, the American Diabetes Association during the past 5 years or so, we have had this thing. So nobody can tell you hemoglobin A1C less than, you have to decide with your patients in front. So if you have a patient that is at risk of hypoglycemia or you're using drugs, you have to be less stringent. If you have a patient that already has chronic kidney disease and multiple complications, well, the train already left the station. It's too late. So you just want to improve glycemic control, and you have to decide where do you want to be the hemoglobin A1C for each patient. So I told you the first few studies in the 90s was bringing down the hemoglobin A1C. Then we tried to be more stringent and get it all the way down. And we had the problem with safety and hypoglycemia. But right now, during the past 5 years, 7 years, now we have changed a lot because we have good data that you can prevent cardiorenal complications in people with diabetes. So if you are in front of a patient, you're going to have two ways of looking at this. You have the glucocentric approach. You just want to bring that hemoglobin A1C down, get glucose control, and you can use all of these drugs. We have 13 different medications with different mechanisms of action to treat diabetes, 13. And all of them work, yeah? So if you have somebody like Arset, young, energetic, you can do, you only care bring that glucose down. But if you have somebody who already have cardiovascular renal problems, who have multiple cardiovascular risk factors, you're going to be selective on the medication. So let me review with you some of these drugs just for you to get an idea where we are on diabetes care. So 13 different, there they are. And each one of them has 4, 6 different types. So it's like going to the supermarket and you have to choose which cereal you're going to eat. So for many, many years, metformin has been the #1 drug. That's right, we all have used metformin. It's been around for the last 50 years. It works well, works fast, no major problem except from gastrointestinal adverse events, no weight gain, and has been shown to decrease mortality in people with diabetes. It has been shown to prevent diabetes. The problem is that you have to be careful in patients who have kidney problems. We don't use when the glomerular filtration rate is less than 30, and you have to use small doses when it's between 30 to 45 because of the risk of lactic acidosis. Unfortunately, there's no good data in prospective randomized studies that once you have established cardiovascular disease or renal disease that had metformin do anything else than bring the blood glucose down. So it doesn't have cardiovascular and renal protection. If you look at secretagogue, the sulfonylurea, the glyburide, the glipizide, well, it works fast, it's cheap, generic, it's as good as metformin bringing the blood glucose down, it's 1 daily dose, but the problem is hypoglycemia. And you already saw the data with hypoglycemia that increased cardiovascular complications. Produce little weight gain, but once established cardiovascular renal disease, the only thing they do is bring the blood glucose down. It doesn't change the natural history in the progression of cardiovascular disease or renal disease. So, tausolidine, There used to be 3 in the market. And believe it or not, 20 years ago, 30% of everybody with type 2 diabetes was on one of these drugs. Triglyceride, rosiglitazone, they went away. One because it was killing people with liver problems, the other with heart problems. But now we have pioglitazone. It works well. It's as good as metformin, blocks an insulin resistance, no hypoglycemia, and it's generic, $5. But the problem is weight gain, that's right. And people gain 2 to 4 kilos. So if I tell you, I'm going to give you this medicine, it's good for your diabetes, but you're going to gain 4 kilos. Ooh, no, doc, thanks. That's right. 80% of people with diabetes are obese. So that is a problem. More importantly, it's the problem of heart failure and fluid retention. And for postmenopausal females, there is risk of osteopenia and bone fractures. And no good data for randomized control trials that you can change the progression of kidney or cardiovascular disease. And finally, DPP-4s. So very commonly used 10 years ago. Right now, the utilization is coming down, but about 20–30% of people were taking it, about now 10 to 12%. The good thing is that it hasn't had major side effects. So you don't know you're taking medicine. It's not very potent. So it's about 0.4, 0.5, that multiple studies have been trying with all of these drugs to improve cardiovascular and renal outcome, and all of them were negative. So far, what we have, all bring the blood glucose down. They are glucocentric, but they don't have cardiovascular renal protection. So what should we do when the patient has multiple risk factors? So age over 55, hypertension, obesity, or established coronary heart disease, or stroke, or kidney problems. You have to select one of these agents, a GLP-1, SGLT2s. And for renal, now we have a new mineralocorticoid receptor antagonist that I'll tell you in a minute how well they work. So I'm sure you have seen this because this is from the cardiologist literature. Multiple trials. In 2008, with the problem with rosiglitazone, if it kill or not kill people, the FDA mandated that every single drug that comes to the market needed to have randomized controlled cardiovascular outcome trials. And what we have is close to 30 completed trials. So let's start with SGLT2s. The cardiologists and the nephrologists use it more than endocrinologists, I believe. So why? It produces glycosuria. It blocks the absorption with the SGLT2s. So if you lose glucose in the urine, you're losing calories. And you tend to lose a little weight, and your blood sugar comes down. It's also produced natriuresis, so positive effects on blood pressures and cardiovascular risk factors. And the good thing is that it doesn't touch insulin. If you get hypoglycemia in somebody, this is because you have an excess of insulin secretion or insulin action. This is glycosuria. It's independent of insulin, so no hypoglycemia if used by itself. So how good it is? Not very good for blood sugars. You get about 0.5, 0.6, 0.8. So if you have a hemoglobin A1C of 10, having a SGLT2s, you're going to be short. You have to combine with the other agents that bring the blood glucose down, with metformin, with the other agents. How good it is for weight loss? The good thing is you don't gain weight like with sulfonylureas or TCTs, but you lose somewhere around 2 kilos, 1 kilo, 2.5 kilos. So it's good enough, but this is not a drug for glucose or weight loss. So the data is on cardiovascular and renal. And you have seen these trials before. A cardiologist, I know that ACC and American Heart always present these trials. So here you have Umpierrez, the first trial, Ghana, Canvas, and DAPA, and decrease the rate of MACE, major adverse cardiovascular outcome, so heart attack, stroke, cardiovascular mortality, but somewhere around 12 to 14%. So it's perfect, it's good. But the data is impressive, is on heart failure. And here you have, you decrease readmission for heart failure in about 30%. And it's a class effect. It doesn't matter which one you use, it's going to decrease. And in patients who have low ejection fraction, the DAPA trial indicated that you have decrease in mortality somewhere around 15 to 20%. Not only that you decrease readmission to the hospital, but you decrease mortality. And if you have preserved or reduced ejection fraction, works 25%. It doesn't matter which one you use. And if you have patients with or without diabetes, it works. So it's now approved SGLT2 for heart failure, both in patients with and without diabetes, in patients with preserved, mildly preserved ejection fraction, all of these nice names that the cardiologists use, Emperor or Deliver, they work. So for everybody with heart failure, this is the drug that you should use. So here's a table of meta-analysis that shows that for 3-point MACE, you have a positive impact. For heart failure, amazing 30% decrease in reduction. And mortality was shown in some of them, not in all of them. So as you know, SGLT2 has changed. The question right now that I don't think we have a clear knowledge is, when do you start? Do you start when the patient is admitted to the hospital immediately, or when the patient is ready to go home? So there are now coming studies like this. Is a pilot study just in 80 patients that you will see to the right is that they were treated in the hospital before the patient went home. And you have decreased readmissions, decreased death, worsening heart failure, and composites of all of these outcomes. Last year, a study from Germany also suggested that the use of EMPA and DAPA shows a significant improvement in rehospitalization and reduction in mortality. So when do we start? Well, we don't know. In soloist, I was in the steering committee for this trial, and sotagliflozin is an SGLT1, SGLT2 combo. So SGLT2 blocks the reabsorption in the urine. SGLT1 blocks the absorption of the glucose or carbohydrate in the intestinal tract. And this was given to patients in the hospital or within 3 days of when they went home. And they saw a reduction in total cardiovascular death, heart failure, and urgent heart failure visit by 30%. This drug is not approved yet. It's under review by the FDA. And they have some problem with Lexicon, who is the company who produced that. They fought with Sanofi, and unfortunately, it's not there. But it has a potential, the same as the other. What is clear is that when the patient go home, is ready to go home, and it go home, or after the patient go home, the use of SGLT2s, it works extremely well, reducing worsening heart failure, hospitalization, cardiovascular death, and all-cause mortality. And there are 2 or 3 studies that are look at the monetary outcome. Is significant cost-effective because you reduce readmission to the hospital. So everybody should be considered as a candidate for an SGLT2s. And of course, I stole this from the cardiology literature. Now it's not 3 pillars, but now have 4 pillars. And the SGLT2, it used to be a diabetes drug. It's not a diabetes drug anymore. It's a cardiovascular and renal protective drug. So SGLT2s also have it's tremendous. It's the best medicine that we have for kidneys. Here you have EMPA, GANA, DAPA. All of them improve outcome for renal outcome. It reduces the progression, doubling of serum creatinine, the need for dialysis, or death in patients who has chronic kidney disease. Having chronic kidney disease, just proteinuria, triple mortality at 3 years. And these agents have been shown to reduce mortality in these patients. So we mandate, or we suggest that everybody who has diabetes should have a urine test every year to look for microalbuminuria. If you have microalbuminuria, what we call UACR, urinary albumin creatinine ratio, that is elevated, I know there is a triple the risk of cardiovascular mortality. And all of these patients are going to be on SGLT2s because multiple trials have shown that you decrease mortality, doubling serum creatinine, and need for dialysis somewhere around 30 to 50%. Very clear. The data is fantastic. And the same for the heart. It doesn't matter if you have diabetes or not. So in the DAPA CKD at the left and the EMPA, they had somewhere around 1/3 to 50% of those with diabetes. The beneficial effects of SGLT2s in the kidney is seen in patients with and without diabetes. So you have glomerulonephritis, you have polycystic kidney disease, give it to them because it also reduced mortality in these patients. So these are the new things the ADA worked with the kidney foundations and produced these guidelines. So if you still use metformin, yeah, it works, bringing the blood glucose down. But remember that if the GFR is less than 45, you just use max 1 gram a day. If it's less than 30, you don't use it because of lactic acidosis. And end-stage kidney disease, dialysis, please don't use it. SGLT2 to the right. And you can do an SGLT2, give SGLT2 all the way to a GFR of 20. And there are now 4 studies, even in patients on dialysis, to see if it reduced cardiovascular mortality. I don't have the results yet. So we use it? Yes, in everybody who has decreased glomerular filtration rate, albuminuria, because the outcome is there. So for you, when you have your patients in the hospital, you start with SGLT2s. This is your issue, is that never use it in patients with type 1 diabetes, never, because the risk of DKA is about 4 to 6%. If the patient has insulinopenia because of 20 years of diabetes, they may be insulinopenic. There is a risk of diabetic ketoacidosis. And if you have somebody who's not eating, you develop starvation ketosis, you may develop full-blown DKA. So be careful. This is rare, but it has been reported in the literature. So make sure the patient doesn't have type 1. Now, do I always know if somebody has type 1 or type 2? No. So if I don't know, I don't use it. But if I have somebody who's a type 2, obese, 5, 10 years, definitive, it should be given to this patient. So what about GLP-1 receptor agonists? So marvelous preliminary data in type 2 diabetes. It worked by different mechanisms. First, increased insulin secretion. Second, decreased glucagon. Remember, glucagon is the most important glycogenolytic hormone. It breaks down glycogen that brings glucose. And so it decreased glucagon. More importantly, decreased gastric emptying. So when you eat something, it doesn't get the glucose postprandial. And decreased appetite. And that's why everybody wants to be on Ozempic. That's right, because with decreased appetite, you lose weight. So it has been that decreased blood glucose, decreased weight, and decreased inflammation. So how good it is for sugar, for weight? Well, here you have. It's as good or better than metformin. It's as good or better than sulfonylureas. It's 10 times, not 10 times, double the effects of SGLT2s. So you get a reduction of somewhere around 1.2 to 1.5% reduction of hemoglobin A1c. And it has significant weight loss that we'll see in a minute, especially the higher dose that we're using these days. And the cardiovascular outcome has been shown now for the last 10 years. That's right. Here you have liraglutide, semaglutide, all of them reduce MACE, so similar to SGLT2s. We have a PCORI grant, and we're comparing now in over close to 1 million people. If you have established coronary heart disease, established cardiovascular risk factors, how well it compares GLP-1 or SGLT2s? No difference. So it's up to you. I say, should I use GLP-1 or should I use SGLT2s? It depends. I'll ask the patient. If he's obese, I tend to use GLP-1. If you're not obese, I'll ask the patient, you want a shot every week or you want a pill every day? Because the protection on cardiovascular outcome and renal outcome is very similar. So here you have different trials. And you have a pool analysis on cardiovascular outcomes, about 15%. So not much different from the SGLT2s in cardiovascular protections. Same thing, the 3-point MACE is seen in most of these. ECCRI is not in the market anymore. And exenatide X-ray is not in the market. So the 3 who are now in the market are going to have a 13 to 14% reduction on MACE. Also, it decreased stroke. We didn't see reduction in stroke with SGLT2s, but we did see in some of these trials with GLP-1. Mortality is decreased in most of these, but about 15%. So prevention not only in the heart, that's right, but the kidneys. And I hope that one of the messages to take home today is that you as cardiologists think of the heart, but please look at the urine and the GFR. If you have diabetes with renal, the mortality of patients with cardiovascular outcome triples. And GLP-1 slow down the progression of kidney disease. So 2024 recommendation is that if you have high risk of patients with established cardiovascular disease, or you can choose whatever you want, a GLP-1 or an SGLT2. So I'm in clinic, 80% of my patients, the average BMI at grade is 32.8. Okay, if you think somebody that is lean, you have type 1. But so you have to choose. GLP-1 is once a week. We still have one that is called the liraglutide that is once a day. But most people are treated with the once weekly GLP-1. We'll talk about that in a second. So either one is good. For heart failure, we would like to use SGLT2s because GLP-1 doesn't reduce the readmissions. However, a paper in the New England not too long ago shows that in patients with heart failure who are obese, GLP-1 improves quality of life. The scans are gradient of monitoring. It helps you to walk better. It helps you to lose weight, but it doesn't change the readmission to the hospital. So heart failure, we still suggest that you should consider an SGLT2s. And this is the recommendation. So the other thing is that we used to treat everybody with metformin. For the last 2 years, we have said that the GLP-1 and SGLT2 should be given independent if you want to use metformin or not. You use metformin to bring that blood sugars down. For cardiovascular and renal protection, is age independent. Here you have, this is a nice slide. Here you have, if you use metformin or don't use metformin, and this is with SGLT2s, no difference. You still protect cardiovascular outcome. If you use here SGLT2s, no difference if you use metformin. And there is no difference if you use it in patients who have hemoglobin A1C greater than 8, fully controlled, or less than 8. So definitive for patients who have cardiovascular risk or kidney problems, they should be given to these patients. For kidneys, you can do it at the GFR more than 20, and we prefer to use SGLT2s. And if that's not enough, you can combine it with the GLP-1, and both have favorable events. So in the last few minutes, let me tell you where we are going to go in the future. So I hope that I travel you from the 80s and 90s, just bring that blood sugar down, 7. Then be careful with hypoglycemia because it kills people. And then we have been the last 10 years, all of these drugs, and now nephrology, cardiology, internists are using the SGLT1 and GLP-1. Unfortunately, GLP-1 is very seldom, it's not very commonly used, despite magnificent data. Less than 12% of our patients are using it. Endocrinologists, about 40%. I don't know cardiologists. And the future is going to be weight, obesity. The reason why there is so much diabetes, because you're fat. So here, 1 billion people are obese in this world. In the United States, 50% by 2030 are going to be obese, more than 30. So the recommendation is that everybody should be advised to weight loss. So how much weight? 3%? 5% improved diabetes care, but improves cardiovascular risk factors. 7% would be ideal. But now we know if you lose 10% of body weight, so if I'm 100 kilos, I lose 10 kilos, diabetes goes away if you have diabetes less than 10 years. So very little requirement of medications, and you improve cardiovascular outcomes. So during the last 2 or 3 years, we have been forcing people to think about obesity, not as a cosmetic disease, as a real disease, because it's associated with multiple complications. So Data from dietary intervention are fantastic in the UK. This data is very commonly shown that if you lose 5 kilos to 10 kilos, 1 out of 3 stop taking medication for diabetes. If you lose 10 to 15 kilos, 50%. And if you happen to be a super person and you lose 15 kilos, so 30 pounds, diabetes goes away. So the problem is that it's so hard to lose weight, that's right. And more importantly, it's harder to keep the weight down. It's very difficult. The National Diabetes Prevention Program in the United States has a success of 30% to lose 3 kilos. Unfortunately, after long term, people regain body weight. So we need help. So in the past, medication for weight loss has been there forever. That you tend to lose 2 kilos, 3 kilos, 5 kilos. And if you stop taking the medicine, you regain. So and the insurance company didn't support us. So very few people, in fact, 5 years ago, were using this medication. But now we have the new trends, right? Higher doses of all of this medicine. So one is semaglutide. When you use semaglutide, you always start at a very low dose, 0.25 milligrams. And every month you increase the dose, 0.25, 0.5, 1 milligram. And that was the treatment for diabetes. You can use up to 2 milligrams for treatment of diabetes. But for obesity, it's 2.4 milligrams. So we use good doses, large doses. And that, of course, suppress appetite, produce weight loss, somewhere around 12 to 14% in people with diabetes and up to 20% in people without diabetes. For some reason that we don't know, or I don't know, I don't think it has been published, is that why, if I give this medicine to somebody with diabetes versus the other people without diabetes, the non-diabetic lose much more weight than the people with diabetes. We have diabetic patients have resistance to GLP-1, and the weight loss is much less. The beneficial effect is there, but of course, we don't have that data. So this is Ozempic, that's right. By the way, we don't use 2.4 milligrams in clinical practice. And we always, if you're going to treat obesity, please work with a dietitian, with a nutritionist. So you cannot see a patient, but the nutritionist see them every 2 weeks. So I see a lot of obesity now. And I see with the dietitian, so she sees them every week or 2 weeks at the beginning. And I see them every 2 or 3 months because it's hard to get an appointment. And it works very well. So the other one is tirzepatide, that's right. This is a dual agonist, a GLP-1, and produce weight loss of somewhere around 22%. So if you have 100 kilos, you get to 80 kilos, the same weight that you had when you finished high school. So it's amazing. And it works very well. You start very little doses. You start from 2.5, you go to 5, up to 15 milligrams. But if you look at here, if even 5 milligrams give you 16% of body weight, not bad. 10, not much different, 10 to 15. And what is coming in the future? Tremendous amount of combination therapy. And now we have the GLP-1 triple agonist that produce a weight loss of about 15, 20%. They're going to be orals. So these are injections once a week. But now in development, there's an oral GLP-1 that give you 15% weight loss. I mean, a little pill every day. And it doesn't matter if you eat or don't eat, just give it, have the same side effects as gastrointestinal adverse events. We're doing now two trials with different medication. The pipeline is incredible. So which are the concerns when you use these medicines? First, for people who is going to have surgery, you have to be very careful. There is the anesthesiologist just published a recommendation, be careful, because one of the mechanisms how they work is by slowing down gastric emptying. So the risk of aspiration is there. So we have to stop this medicine, or you have to let the anesthesiologist know that this patient has been on GLP-1 before surgery for the risk of aspiration. The other is pancreatitis. It should not be given in patients who have history of pancreatitis because the rate of pancreatitis is small, but it's higher than other medications. And the other thing is that produce a lot of nausea and vomiting, like 30%. So you have to start very low dose and increase the dose slowly in the future. But where are we going to start? We're going to go in the future, who knows? I guess we're going to have multiple, triple, and quadruple agonists. So the American Diabetes Association have worked with the American College of Cardiology, but we've always been behind. And about blood pressure and lipid management. For the first time ever, now we say blood pressure should be less than 130/80. We used to say 140/90. I mean, get out of here. Everybody was saying 130/80. We said, no, 140/90 should be okay. Now, finally, we joined the club 130/80. Good. The other thing is how we manage hypertension. And this is a little different from most other organizations. We look at the urine. So the first thing I do when I treat hypertension is look at the urine. Because if the patient has albuminuria, I'm going to use ACE or ARBs. And it doesn't matter what you have, that's right. I mean, then you combine this medicine. And the other thing is that it's more than 160. I use 150 or 100, two medications at the beginning. And of course, if albuminuria, I do ACE, and ACE reduce albuminuria by 20%. So more than 50% of patients remain with albuminuria. So I use an SGLT2 on top. The other thing is that ADA has been frustrating, and we push so hard, but the standard of care is a bunch of people. I've been there 2 cycles, so it's a lot of discussion, very little in writing and recommendation, but we want to reduce LDL by 50%, and hopefully everybody with LDL less than 70. And when I brought this to you, is because for the first year, we moved this. We said everybody over the age of 40 should be on statin. Okay, good, I got it. But we didn't know from 20 to 39, and we have tons of people. And now we recommend those who is less than 40, if they have risk factor, please use statin therapy in these people. And you want to achieve an LDL less than 100, or hopefully less than 70 for most people. And we're pushing to combination therapy. That's right, ezetimibe, it's commonly used. But PCSK9, I don't know if the cardiologists are using you or sent to the lipid clinic, but why do you have to give, you can give this injection, patient can do it sub-Q every 2 weeks. So the problem is insurance companies. But we should, general doctors and cardiologists and endocrinologists and everybody who treat people with diabetes should consider using PCSK9 because the data is very strong. And last year we changed for the first time age. So there's no age limit. That's right. I mean, if you are a young 75, please start statin low dose because of side effects. And if you are over the age of 75, please don't stop it if the patient is tolerating because the efficacy is there. So what I try to tell you today is that we've changed a lot. First, diabetes is the leading cause of blindness, amputations, dialysis, and that is glucose dependent. Bring that glucose down from the beginning. So a young person, this is going to be around for the next 10, 15 years. Please bring that hemoglobin A1C less than 7 or around 7. Avoid hypoglycemia because, of course, so only 2 drugs produce low blood sugars, insulin and sulfonylureas. So avoid them as much as possible. Many patients need insulin, of course, but be aware that you don't want to have a hemoglobin A1C of 6.5 if you're treated with insulin, except if you're type 1 young. And third, we have gone from efficacy, safety, drug dependence, according to cardiovascular and renal outcome, because these drugs are, like SGLT2s and GLP-1 has really changed and modified the way we think. And the future, obesity. So if we can prevent obesity, the best way to treat obesity is prevention. That's right. Please don't gain weight. But we should have established obesity. Now we have medication that really has improved significantly the outcome. So new era, the SGLT2s and GLP-1 for cardiologists. New, more potent dual and triple agonists are coming. We don't know the cardiovascular outcome, but tirzepatide is just going to publish, haven't seen the data, but just publish the summary that is also improved outcome, the same as the semaglutide. And so hands-on. You have a copy of this, and I sent it to you, and if you are very welcome to use these slides or throw them away. So question, comments?
Thank you very much. That was superb. Thank you. I'll start with questions, but I'm sure there will be others. So this epidemic, or if you like to call that, of diabetes, is it attributable only to the epidemic of obesity that preceded it, or are there other reasons you think?
So I think that it's multiple factors. First, we don't move anymore. We just don't do exercise. We don't walk. Obesity is the #1 reason, but there is genetics is important. I read this in New York Times, okay, but just take it like a New York Times paper. Why there is so much diabetes in India? You know, India has 100 million people with diabetes, and every year 10 million people join the club. 10 million people. Why so much? It's the #1 country in the world. And they say that is famines, that they have gone through multiple famine episodes. And when you go through this, that happened in Africa, that happened in low income. And if you are hungry, you change not the gene, but the gene expression, what's called epigenetics. And what you do is epigenetic changes make your body to be more resistant to starvation. Now that we live in the midst of plenty, now these genes that were resistant to starve, to prevent starvation, is attacking them. And that was one of the main thoughts about diabetes in India. We have a national education program in India, and it's just amazing the number of people with diabetes. And this is a poor country, that's right. The good thing is that medicines are cheap there in India, but it's a big issue. So it's genetic, epigenetics. Why so much in low-income people is because the way they eat. I mean, it's easier to go to McDonald's than to have lettuce and tomatoes, but it's more than that. It's very complex. So can you imagine having a country that 10 million people, new patient with diabetes? I mean, the cost is just brutal.
So,
yeah.
Would you ask a question, but anybody online can put comments in as well. So I have somebody say with a A1C of 6.5, I'm going to add an SGLT2 or GLP. Should I stop the metformin, or because neither of them are going to cause hypoglycemia, or just give it?
So that's an interesting question. I mean, how we diagnose diabetes, that's right. And this has changed. 10 years ago, we only looked at glucose and oral glucose tolerance tests, and 12 years ago, we added hemoglobin A1C. This year, we put hemoglobin A1C as the first-line tool to diagnose diabetes, more than 6.5. And when do you start? For pre-diabetes, so if you are less 6.5, oh, one more thing about hemoglobin A1C. If you're Latino, you're Black, you tend to have 0.3, 0.4% higher hemoglobin A1C for the same blood glucose. So when do I start thinking about metformin for pre-diabetes? When the blood glucose is 100 to 125, the definition, when it's above 110. So if you pass the 110 range, you're going to get diabetes. And hemoglobin A1C, we say 5.7 to 6.4. If the hemoglobin A1C is greater than 6, you have to be treated. So your patient, you say 6.5, so that's in between, that's right. The only drug that has been recommended right now is metformin. However, saying that, every single drug except sulfonylureas prevent diabetes. All of them. If you use a GLP-1, 90% of pre-diabetes will go to normal glucose tolerance. 90%. SGLT2 the same. All of these drugs work. But metformin is cheap, has been used for 50 years, so it works well. So I don't care glucose, but if I have cardiovascular risk factors. So pre-diabetes, why do we care diagnosing pre-diabetes? Because of cardiovascular mortality. It's increased by 2 or 3-fold. Just for being pre-diabetic, because usually you're obese, hypertensive, have cardiovascular risk factors. So if the cardiovascular risk factors are there, you are 55, I may use an SGLT2s with or without metformin. Metformin for bringing the blood glucose down, but SGLT2 should prevent diabetes in the same way. Did I answer you? But metformin still, I mean, it was my first love. That's why it's the drug that I learned forever. So I can't. You don't have to use metformin. Yeah. We said since last year, the ADA says that independent of metformin, you should use this drug for cardiovascular and renal prevention. Independent. Is if you have albuminurias, I don't think metformin. I would use SGLT2. So you have cardiovascular risk factors. I don't care about metformin anymore. I mean, I do care to bring the blood sugars down because you don't pee, you have better quality of life. If you think you're going to be alive 10 years, you can prevent chronic complications. But these drugs are independent of metformin. Don't use metformin except for bringing the blood glucose down in most people.
I have two questions. One is I wanted to know your thoughts on Finerum, the last one, the MRA.
And the finerenone. Yeah, and I took it away. We participated in Fidelio and Figaro in these studies. This is a third-line mineralocorticoid receptor antagonist, that's right, and has been shown in patients with diabetes to prevent cardiovascular and progression of kidney disease. Now there is a trial that is called FIND-CKD that we're participating in people with no diabetes who has chronic kidney disease. Can you have the same effects? Now we also have a trial that I'm in the steering committee. It's called Confidence. And this is finerenone, empagliflozin, SGLT2s, or the combination of both. So how well do they stand in high-risk patients and patients with chronic kidney disease compared to SGLT2? So maybe the combination of both should be okay. And the final studies that we are participating is called FIND-1. It's in patients with type 1 diabetes. So if you have type 1 diabetes and you already have some chronic kidney disease, you already have albuminuria. The only thing that we have for the last 20 years is ACE inhibitors. But ACE inhibitors doesn't prevent progression of kidney disease in everybody. So can we use finerenone in type 1 diabetes? I'm extremely pro because we don't have anything for type 1s. And this is the drug that maybe is going to help progression of kidney disease in type 1 diabetes. You cannot use SGLT2s in patients with type 1 because of DKA. So you're naked. I mean, yeah, a little lisinopril, but you still have proteinuria. So FIND-1 should be great. And with Miguel Cosiboro just invited us last week, they're doing a trial on heart failure. The same thing, and you can do it with or without SGLT2s, but see if it will help or not. We have not started that, but this is an investigator-initiated study by Cosiboro, and maybe it's good. So I use it, yeah. We don't have it at grade, I mean, at the formulary, so I'm participating in a lot of these studies, but not have the experience, but it works extremely well. The only problem with finerenone is hypokalemia that is seen in about 12% of people. So you have to measure potassium 2 weeks later and every so often, make sure they don't go too high.
My second question was just, when you stop the GLP-1, weight's going to come back, right?
Mhm.
So is there any, do we just leave them on the semaglutide indefinitely for the rest of their life, or what,
Yeah. So
side
the
effects?
answer is yes. And I can share my tremendous frustration. If you start somebody on semaglutide or tirzepatide, I've seen patients losing 40, 50 pounds. And the trial ended. And 3 months later, they have gained half of they lost. And you ask them, did you change your eating habit? No. So I think that people who are obese have amnesia of what they eat. So they don't remember that they gained it, and 2 years later, they all gained the way back to where they were before. So it is a problem. I mean, the utilization of GLP-1 is going to change because now you lose more than pounds. So be careful if you lose 30, 40 pounds. You lose a lot of fat, but you also lose muscle, which increase the risk of fractures, the falls. So now I'm extremely careful in the older adults, for those who have some studies. You have to advise them, make sure you don't get rocks on the floor, minimize the risk of falls, because your muscle, same as fat, is going to go away.
We have one question. Combination of SGLT2 and GLP-1.
Yeah.
Is there a synergistic cardiovascular risk reduction?
I don't see any trial, but retrospective data suggests that yes, there is a synergistic effects, but there's no combination therapy that I've seen in the literature that retrospective data will suggest, and we use them all the time. So if I don't achieve what I want for glucose or cardiovascular risk factor, definitely if I combine the two, we do that all the time.
You have to take out a mortgage as well, right?
Yeah. Well, now SGLT2s, well, let me just tell you the final story that I think is fascinating. Dapagliflozin should have been generic this year because the patent was in. So because it was developed as a sugar medicine. But of course, business, no, we don't care about sugar. We care about the cardiovascular and renal protection. So got the new indication. Now you have to pay $5 for the next 15 years. So it's not going to be generic up to 30 something. None of these drugs, because they are not diabetes. Who cares about sugar? Now we care about the heart and the lungs and the kidneys. All right. So thank you so much.
The preceding program is copyrighted by Emory University.